Hi, my name is Dr. Robert Kaufman, and we're about to go beyond the terminus. Here's an interesting case that I did in 2024. It's a maxillary first premolar with a history of full crown restoration. The patient's mouth is heavily restored with crowns. The patient presented with buccal palpation sensitivity in the periapex area and slight percussion sensitivity. Perio findings were within the range of normal. Radiographic examination showed a periapical radiolucent finding associated with the apex of the first premolar. Pulp tests were normal in the adjacent proximal teeth, but non-responsive in this tooth. In cases where there is a periapical radiolucent finding and the tooth is non-responsive to pulp tests, I will frequently offer to perform treatment on patient without local anesthetic. In non-vital anterior teeth with radiolucent areas and confirmed pulpal necrosis, patients are astonished that I can perform treatment without anesthesia. It certainly is a great practice builder, and if your assistant is careful with the rubber dam clamp, there's often very little discomfort at all. This patient elected to go without a local anesthetic, and I attempted to make access through the crown. I could tell from the periapical radiograph that while the access to the chamber and canals look fairly straightforward radiographically, the placement of a crown can sometimes alter the perceived direction of your access. Finding the canals appeared to be a lot more difficult than I anticipated, and I ended up taking a bitewing to ensure that I was not drifting distally with my access. The normal dentin coloration that is visible to all of us that we see during scope use really didn't help that much because the access was so small and the amount of light entering the access was minimal. I re-angled my access and elected to try to find the palatal canal first. I was surprised to see a bleeding point and a reaction from the patient when I explored the palatal orifice. Although there was periapical radiolucent finding indicative of pulpal necrosis, the calcification in the chamber had walled off the necrotic buccal canal contents from the vital palatal canal contents. I anesthetized the patient and used the bleeding point to move buccally and slightly mesially to find the necrotic buccal canal orifice. Had I not gone without a local anesthetic, I may have further needlessly enlarged the access in an attempt to find the canals, or maybe even perforated the case. Even still, in the bitewing, you can see that my access was drifting too far distally than I liked, and I dinged the canal wall, as we call it. The final access is larger than I would have liked, but at least I found the canals and completed the case without too much loss of dentin. When you're accessing through crowns and may be unsure of the direction that you're going, it's helpful to remove the rubber dam and take a bitewing or PA to confirm the direction of your access doesn't result in perforation. It's far better to take your time, go slowly, and check the orientation often with multiple images or a CBCT than to have to explain to the patient why their tooth has been compromised by an errant access. Thank you for joining me this edition of Beyond the Terminus. Remember, when we do the right thing, we both get better, patients and clinicians. Please remember to subscribe and like. This channel is unsponsored to bring you unbiased information from a practicing endodontist of almost 40 years. Your suggestions and topics for comments are always welcome. You can put those in a comment box at the end of each of these videos. I look forward to our next trip when we go beyond the terminus. See you then.